Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss a very important topic and it's a recent recall. It came in November 2023 exam. We have a patient, she's pregnant in a twin pregnancy and she has a baby with cystic fibrosis. So she's here today in the antenatal care clinic to discuss how to screen her babies to be sure that if the babies are affected or not. So here we have the patient. Her name was Manor. She's 25 years and she's pregnant 10 weeks with a twin pregnancy, and she's part 1 with the cystic fibrosis child. She and her partner were screened and they are carriers for the gene. Now she's here to discuss the screening of cystic fibrosis, and be sure that you are aware about the agenda, what about the main concern of the patient, and while you are setting the agenda with the patient, you will be sure that, yes, she's here only for the screening. It's a very important point. And if the patient will ask you any question, any further question in the management, yeah, we will cover at that time. You will be assessed in these domains. Usually in the exam, it will be 4 domains, but for the practice, try to put all the domains together, like information gathering, applied clinical knowledge, communication with the patient, communication with the colleagues, and for sure, our tricky domain, the patient safety. So let's go introduce yourself first and ask the patient how would she like to be called? How would you like me to call you? And then set the agenda. What about our agenda here? She's pregnant and she wants to discuss the screening test, and then ask the patient, is that correct? And ask her if she has any other concerns or expectations from this consultation today, and then tell her that you will address all her concerns. However, you want to ask her a few questions before proceeding forward. Information gathering, we are here in the antenatal care module, and we will follow its template. So we will start to ask about the pregnancy, and for sure, we will start with open question. Don't forget, my friend, that this is the best way. So the first question has to be, how is the pregnancy going so far? Any problems during this pregnancy? What about the folic acid, the blood test, and the scan, if it's done or not? What about the future fertility wishes? Because we will reflect on that to tell her about the pre-implantation genetic diagnosis by the end. Any family history of cystic fibrosis, we can consider this part of the history of the present illness or the family history afterwards. And don't forget the baby, just to make like a good communication with the patient. So ask the patient, what about the name of the baby and what about the health of the baby? How's he doing? And also if she's coping or not, and her partner as well. And usually the babies with cystic fibrosis or any patient with cystic fibrosis, the most common problem will be the chest infection. Even this is the cause of death in most of the cases. So we need to ask about coping, and also how is the baby, ask about the name of the baby as well. Personal history, to ask about the smoking, alcohol, recreational drugs. It's very important in any pregnant lady. The BMI as well, as part of evaluation or assessment of the risk of clot formation or VTE risk. Menstrual, if you want to be sure about the date, ask about the last menstrual period. You can ask even about the pregnancy, if it's like spontaneous or after treatment or a tested tube baby. Obstetric, what about the mode of the delivery? We know that she's para 1. So what about the mode of the delivery? What about the recovery afterwards? And if she has any or had any problem at that time. The blood group here, it's part of the safety for any pregnant lady. And please don't forget, if this patient RH negative, counsel her immediately. This is my advice. Exactly like smoking. If the patient is a smoker, you will counsel her immediately about smoking cessation program clinic. And if she wants to be referred, you will do that for her. The same here, if the patient RH negative, just tell her that there is 2 injections to be given. One will be in between 28 to 32 weeks, and another one, it will be after the delivery, it will be postpartum. The best time window to be within 72 hours after the delivery, up to 10 days. And in our patient specifically, we will give another injection after the invasive testing. If you will offer her the needle test, chorionic villus sampling, or amniocentesis, please don't forget that this patient will receive anti-D 250 international units after the invasive testing. Ask her also about any concerns regarding blood transfusion, and for sure the drug allergy or any allergy from drugs or special food or anything. It's the safety points of all modules. So please, guys, keep the allergy in your mind. Another way, and it's another advice from my side to avoid, like, not to forget the drug allergy, keep it with the medical history. So let's go to the next slide and I will show you how. Here, the medical history will ask the patient, do you have any medical problem of concern? Do you use any regular medications or visit your GP for any chronic illness? And here, just add the question of the drug allergy, so you will not forget it. Keep it with the medical history. Then ask the patient, do you have any surgeries done in your tummy or down below before? Do you have any family history of concern? Especially for any congenital anomaly, cystic fibrosis, any problem like clot formation. Mental health, it's very important in this station because this patient with a child with cystic fibrosis, she's now pregnant, so she's anxious. She's all the time, she will think about her babies. So we need to ask her the two holy questions. Did you feel depressed, low, or not interested to do your usual activities in the last 4 weeks? Okay, guys, very important question. And usually this patient will be affected and you have to refer her to a counselor or attach her to the counselor. Social, what about support at home? Again, another important question. Then just say, thank you for sharing this information with me, because it's like confidential information and the patient shared this with you. So you have to say, thank you. This is the first purpose. And the second one, just to take like a pause, like for 10 seconds to go to the next step. Next step will be examination. And here examination plus or minus, it will depend on you. So if you want to examine, just explain why do you want to examine the patient. Okay. This is the last thing from the RCOG. Like if you want to examine, yes, you can do that, but you have to tell why do you want to examine the patient. She's pregnant. We may need to check her blood pressure, the pulse, temperature. We need to check her tummy and her general health. After that, we will go to the explanation before the management. So you have to check the knowledge of this patient because already she has a child with cystic fibrosis. And you will find the patient, she knows the condition, but she will need to know more about the risk for her babies. So this slides if the patient doesn't know anything about the cystic fibrosis. But if the patient knows some or little or piece of information and you need to add more, so you will explain more about the risk. So cystic fibrosis, it's inherited disorders and it's caused by mutation in a particular gene pair. And please, when you will mention the genes, explain what are genes, okay? So usually it's diagnosed in the childhood and it's the most common serious genetic or inherited disease in the white European population. The risk of cystic fibrosis, by the way, guys, it's very common here in UK. It's around 1 every 25 a carrier. So it's quite common. And 1 every 2,500 diseased, or 3,000 in some papers. So that's why here cystic fibrosis is very important. Even we have here clinics for cystic fibrosis only because of the chest infections. Okay, so it's very important to cover. What about the genes? They are unique set of instructions inside our bodies. It's one definition. And actually, I love another definition. You can tell the patient that it's a tiny structures inside our body and it carries the information for everything, like the color of the skin, the color of the eye, the color of the hair, even the disease we will develop in the future. Okay? And in the cystic fibrosis, we have like affected gene. And another information, this is for yourself, it's not for the exam. The exact site is F508. This is the exact site of the mutation for the cystic fibrosis. Okay. This condition is autosomal recessive, so we need the 2 sets of the genes to be inherited. Then explain to the patient that we inherit the 2 copies from the dad and mom, or one from the mother, one from the father. If you want to draw for the patient, just to explain the risk, and will be the next task, just to explain what about the risk in the babies. So you can tell her that if we will imagine that now you are a carrier, this is the normal gene and this is the diseased one. This is you and this is your partner. He has also, this one is free and this one is diseased. So you have 25% chance, or 1 every 4, you will have a healthy child. And you have 50% carriers. And if the diseased one will meet together, so you will have 25% chance to have a diseased baby. Okay, so 25 or 1 in 4 will be healthy, 1 in 4 will be diseased, and 1 in 2, 50%, will be carriers like you and your partner. Here is how to explain. You can draw even in the exam, because sometimes because of the stress of the exam, you will make mistakes here. If you will draw, you are drawing for the patient and yourself as well. So you will not do any mistakes in this. If the patient knows everything about the cystic fibrosis, so you will start to explain the genes and how this disease is inherited, and then you will give her the chance having a healthy baby or a diseased or carriers. Then we will go to the management plan. I will go backwards. Sorry, there is like the slide of the management. It's before the explanation here. Here, don't forget, it's not multidisciplinary team. Usually I'm putting this in red just to remind you, friends, that please don't forget the group of expert team. We are not managing the patient alone. Here we need to involve the consultant, the nurse, the midwife, fetal-maternal medicine unit team. And sometimes you can add here also the counselor in the team. The multidisciplinary team can be involved if we will choose, or if the patient will choose like selective termination, or it will be like a complicated case at some point of time. So yes, you can involve the multidisciplinary team in terms of multidisciplinary team. But from the start, it will be the group of expert team. What we need to do, we ask the patient about booking investigations. If it's done, okay, we will check the results. If not, we will offer her the booking investigations, the blood test. The ultrasound was done for her, and just they told her that it's a twin pregnancy, but we need another detailed scan. Please don't forget it. Another important point in the knowledge. So we need to check the chorionicity, how to explain the chorionicity for the patient. So you will tell her that we will offer you a detailed scan. To be sure, what about the afterbirth? We need to be sure if the babies are sharing the afterbirth or not. So if they are sharing, this is a monochorionic. If they are not sharing the afterbirth, this is the dichorionic. And please don't use monochorionic, dichorionic. It's medical jargons. And if you will use it by mistake, explain immediately. So you will offer her this scan and the blood test if it's not done. And then what about the options available for these patients? You will say we do have 2 options for you, either to offer you the invasive testing or the non-invasive testing. Coming to the invasive testing, we have 2 types of that. What we named medically chorionic villus sampling, where we can take a sample or a piece of the afterbirth. How we will do that? We will numb the area, we will numb your tummy, and we will insert a needle, and it will be under guidance of ultrasound, and we will take a small sample of the afterbirth. If the babies are sharing the same afterbirth, we will take only 1 sample. If the babies are not sharing the afterbirth, so we need to take 2 samples. You can here again draw for the patient and tell her, imagine that this is your womb and we have the pregnancy here. This is the afterbirth. If they are sharing the same afterbirth, we will go inside, take 1 sample and out. But if this is your womb and we have 2 different afterbirth, we have to go 1 time here, take the sample and then out. Again, we will go in and then out. Okay? And when you will draw for this patient, it will come the rest of this procedure. So you will tell her it's done under the guidance of ultrasound. It will be done with expert hands, especially in twin pregnancy, guys. It has to be done in the fetal-maternal medicine unit. And the person or the one who will do it has to be expert in dealing with the twin pregnancy, taking samples in a twin pregnancy. It carries more risks for the twin pregnancy more than the singleton. So the risk of infection is there, the risk of pain is there, the risk of miscarriage, and take care that risk of miscarriage now, after the recent update, it's 1 every 200 in the singleton, but take care that in the twin, it will be 1 every 100. So it's double the risk. Regarding the miscarriage, another risk, and you will get the benefit from the drawing by telling the patient sometimes with all this effort, we will go and take the 2 samples from the same afterbirth. Like we can take the first sample from this afterbirth, and again, we will take the second sample from here. So it will lead to incorrect diagnosis or incorrect results. Take care of this. It's a very important point, and it's noted clearly and written clearly in the guideline, the recent one of the chorionic villus sampling and amniocentesis. This patient is 10 weeks, so most probably we will offer her chorionic villus sampling. Touch the point of amniocentesis, we can do it by taking a sample from the water around the baby, but it's done after or around 15 weeks onwards or forwards. So it's not done now, but what we can offer now, the chorionic villus sampling. And we will use the same technique, like to numb the area under guidance of ultrasound, insert the needle, but instead of taking a sample from the afterbirth, we will take it from the fluid around the baby or the water around the baby. Okay, so this is the invasive. What about the advantages? If we have options, guys, and use it in all our curriculum. Any options, please give the pros and cons, advantages and disadvantages. The advantages here that it's accurate. So we will be sure about if we are taking the samples in a good way and in the correct way from the 2 afterbirth, or if they are monochorionic and we'll take 1 sample, so it's accurate. However, it carries the risks, as I told you, infection, pain, miscarriage, and inaccurate results if the babies are not sharing the same placenta. Here is the explanation of the chorionic villus sampling, but it's better to draw for the patient. It will enhance your communication and it will make it easy for you. And it's done between 11 to 13 plus 6 or 14 weeks. Here we have extra information. It can be done trans-abdominal or trans-cervical, but usually this is the most common method used, so don't mention this in the exam. And the test itself will take around 10 minutes, the procedure. The risk, as I told you, and here I put this in red, don't forget, it's 1 in 100 in the twin pregnancy. Inaccuracy because taking of samples from 1 placenta or 1 afterbirth. Here we will go to the non-invasive diagnosis. And here, guys, please just pay more attention with me because there is a conflict between the non-invasive prenatal diagnosis and testing. We do have 2 different, it's the same technique, but we are using the diagnosis in some conditions and NIPT in another conditions. So we will take a sample, how to explain it to the patient. You will tell her that normally, this is a normal event that some of the baby's blood will escape into your blood around the 10 weeks. So we will get like a blood sample from you and it will be examined under microscope to determine the baby's blood. And this baby's blood will be examined. Full stop. This is the technique, how we will do it. And also you will explain to her, this is a normal event. So it will not be like, the patient will not be scared how the baby's blood will come inside my blood. What about the advantages of the non-invasive prenatal diagnosis? Avoid the chorionic villus sampling, amniocentesis, and remove the risk of miscarriage. Very important. It's available for the twin pregnancy. And here, this is another conflict. Take care that in some papers, it's written, it may not be possible. So it may, it doesn't mean that it's not possible. Still, it's possible. It will depend on the method used or the technique used, and it will depend on the laboratory. So the patient has to check with the laboratory if the results will be accurate or if this test is available with the twin pregnancy or not in this laboratory. It's a diagnostic test. What is the meaning of that? If you remember NIPT testing in Down syndrome, if it's positive or high risk, again, the patient has to go to the invasive, the needle test, to have diagnosis. But here, if we have the non-invasive prenatal diagnosis and it's positive, So at that time, it's diagnostic test. No need for any further step. We can start as early as 8 to 9 weeks. So we have here the advantages. Please don't forget to tell pros and cons as we mentioned. When to use the NIPD, the diagnosis, in specific conditions, and usually this is a genetic, in the genetic conditions like Duchenne myopathy, Becker muscular dystrophy, spinal muscular atrophy, congenital adrenal hyperplasia, and cystic fibrosis. So as you can see, it's all genetic problems. When to use the NIPT, it's used in the trisomies, like trisomy 21, the Down syndrome, trisomy 18, trisomy 13, and so on. Here, as I told you, we said, or we told the patient about the advantages. So what about the disadvantages here, guys? As you can see, it's full of advantages, isn't it? Yeah, but what about the disadvantage here? Because it's not funded by the NHS. So the invasive, it's funded by the NHS. The patient has not to pay anything. But for the NIPD, no, this patient has to pay for it. So it has to be like in a private place, to be done in private. NIPD versus NIPT, very important slide because it's a conflict. Most of the candidates will not be sure what about the difference between the two methods. Usually we are using the same technique in the two tests, but this one, as I told you, it's used for the genetic problems like cystic fibrosis, and this one in the trisomes, in the chromosomal abnormalities. It's closely related to the similar method. This one, the NIPD, it's similar method to the non-invasive prenatal testing. In both methods, we will take the blood samples and it will be examined in the laboratory. The difference here will be that NIPD considered diagnostic, one of the advantages, with no follow-up invasive testing. But the NIPT for the aneuploidies, it's regarding a screening test. So what is the meaning of that? If it's positive, we will go to invasive testing. Okay, so we have to offer invasive testing afterwards. So remember, NIPT in the chromosomal abnormalities, NIPD in the genetic disorders. Future pregnancy, touch the point of future pregnancy. You can tell the patient before you are planning to a baby, we can offer you what we name pre-implantation genetic diagnosis. And here again, it's not funded, guys, by the NHS. Very important point. So how we will do that? It's like exactly the same. It's a test tube baby, but before moving this baby inside your womb, it will be examined under the microscope. So how to explain this to the patient in layman language? So you will tell her that we will get the egg from you and sperm from your partner, and we will mix it together in the laboratory. Fertilization will be done when the baby is ready. Before taking the baby inside your womb, it will be examined under the microscope to be sure that we will not move or put inside your womb any diseased baby. So we will move only the healthy one. This is the pre-implantation genetic diagnosis. So we have to cover this, especially if the patient, if you asked her about the future fertility and she said, yes, I need to, or I want more babies. Here, we are done with the counseling. The patient has to choose. If the patient wants to think, give her the patient information leaflets and another appointment, and give her the window of the chorionic villus sampling. It's very important. And if the patient asks you about what about the further step, so at that time you can cover if we have like affected baby, one baby or two. So either to continue the pregnancy or to terminate the pregnancy, the whole pregnancy. But if one baby is affected, you can offer her selective termination. And at that time, again, it has to be done by expert hands, and it will carry risks for the baby, for the other baby. Don't forget the patient information leaflet. It's crucial here. And please, if you cannot or you are not able to finish in the 10 minutes during your preparation, keep this ending at the start by saying by the end of our consultation, I will provide you with the patient information leaflets or the written information. I will set another appointment with my consultant and I will arrange for the test, and I will attach you to support group, people with the same experience to know how to cope with your condition or how to deal with your baby. The patient safety points here, guys, good explanation. Take care that it's part of the Communication and part of the safety. Appropriate management plan, the correct plan. Drug allergy, VTE risk assessment, very important. Complications of the invasive testing, very important to mention. Support, tell the patient that we will support her wherever her decision. Okay, friends, I wish this is clear. It was the last slide. So that's all for today. Thank you so much. And if you have any queries, please don't hesitate to send any, just drop a message in private or in the group. Thank you so much. And Assalamu alaikum wa rahmatullah.